Hello, folks. Reed Live here. Today, we're going to have a very interesting conversation. We're going to talk about the neuropsychiatric manifestations of HIV infections. Yeah, HIV. Now, remember, um, the treatment for HIV has been so effective that it's possible to um, not detect the virus in the peripheral blood system, right? But just because you don't find it in the peripheral nervous system doesn't mean that it's not in the central nervous system, right? So HIV has a predilection for the central nervous system. And even though you can test negative for it, it can still be there populating inside of the body. So because HIV has a predilection for the nervous system, then when we see patients with HIV infections, we also see some of the soft neuropsychiatric manifestations of the infection, right? And it typically shows up with inflammation. You know, when it comes to the brain and when it comes to creating psychiatric symptoms like psychoticism or mood-related disorders or cognitive disorders, they almost always is connected to inflammation somehow. And there's the mechanism. HIV typically results in some degree of inflammation. The inflammation disturbs the blood-brain barrier. The blood-brain barrier is no longer semi-permeable and therefore lets everything in. And that's not good for a circuit system. It's not good to have everything floating around a circuit board, right? I mean, the central nervous system is a pristine environment where the whole brain, the brain and the spinal cord is suspended in a fluid, a cerebrospinal fluid. I call it holy water. I guess it's the closest thing to holy water you can get. Your nervous system is suspended in it. And that's a specialized fluid. When you open up the blood-brain barrier, you disturb the space and nothing works in it. So we're going to look at today, we're going to look at HIV infection, the neuropsychiatric manifestation of HIV infections. Let me see. And here I have ChatGPT. Explain the neuropsychiatric manifestation of HIV infections, particularly focus on the disease process, explain the neuropsychiatric manifestations of HIV infection, particularly focus on the disease process and symptoms. Okay. Let me see what we have here. Okay, now we're getting here. Okay, so let's see here. Okay. So here, explain the neuropsychiatric manifestation of HIV infection, particularly focus on the disease process and the manifestations of neuropsychiatric symptoms. That's my question. Excellent question. The neuropsychiatric manifestation of HIV infections are a major area of study because HIV is not only an immunologic disease, but it's also a neurotropic disease. HIV is not only an immunological disease, but it's also a neurotropic virus. Neurotropic virus, meaning it directly and indirectly affects the brain's nervous system. Let's break it down. So, yeah, remember neutrophils, right? Pathophysiology, how HIV affects the brain and nervous system. Okay. Neurotropism and CNS entry. HIV enters the CNS early in infection, often within days to weeks after exposure. I mean, this thing is rapid. The virus crosses the blood-brain barrier primarily inside infected monocytes and macrophages, a process called Trojan horse mechanisms. Wow. Once inside, HIV affects microglia and perivascular macrophages, the main immune tissue cells of the CNS. So basically, the Trojan horse pathology. Wow. The blood-brain barrier through macrophages, infected monocytes. So HIV gets into the nervous system by hiding inside of the immune system cells. Oh, okay. Cellular and molecular effects. Unlike other tissues, neurons themselves are not directly infected, but they are injured by neurotoxic viral proteins. Remember GP120, TAT, and VPR? Wow. Inflammatory cytokines, tumor necrosis factor, interleukin factors, right? Excitotoxicity via glutamate dysregulation, and oxidative stress via mitochondrial dysfunction. So yeah, so this is the interactions that the virus has with the cells in the nervous system. So this is interesting. So some of the proteins inside HIV are neurotoxic to the cells. So yeah, unlike other tissues, neurons themselves are not directly infected, but they are injured by the neurotoxic viral proteins, inflammatory cytokines, excitocytation, and oxidative and mitochondrial dysfunction. That's great. The result is neuronal injury and synapses loss, particularly in the basal ganglia, frontal cortex, and subcortical white matter. Wow. So HIV, it enters the nervous system through infected monocytes, macrophages. Then it can also enter the nerve cell, the tissue, brain tissue itself through the microglia and the perivascular macrophages, right? Okay. Then the proteins itself can cause the cell to malfunction. In response to the virus, the immune system will produce inflammatory cytokines such as tumor necrosis factor, interleukins, things like that. And of course, these generate more of an immunosuppressive response. Then through excitation, remember, glutamate, go to the lecture I have on glutamate, the neurotransmitter glutamate. And remember, glutamate is the main excitatory neurotransmitter. So basically, excitotoxicity via glutamate dysregulation. So you turn the glutamate on, then basically you have a situation where you're going to ride till the wheels fall off, right? Okay, then oxidative stress and mitochondrial dysfunction. This is where you decouple APD, you decouple the production of ATP, right? I think this is the oxidative stress and mitochondrial dysregulation. The result is neuronal damage, injury and synaptic loss, particularly the basal ganglia. So basal ganglia, frontal cortex, and the subcortical white matter. That's the cellular and molecular effects of HIV. Okay, HIV-associated neurocognitive disorder spectrum. The hand spectrum captures the neurocognitive decline associated with HIV. Yeah, that's one of the things we want to follow too, is this neurocognitive decline in HIV. Asymptomatic neurocognitive impairment. Mild deficits only detectable by testing. Yep. Asymptomatic neurocognitive impairment. Yeah. See, I picked up a mild neurocognitive disorder. Yeah. Mild neurocognitive disorder, mild dysfunction impairment in daily activities. Yeah. HIV-associated dementia, severe cognitive and functional decline, historically called AIDS, dementia complex. Okay, great. Asymptomatic neurocognitive impairment. I always looked at that as the same as mild neurocognitive disease disorder. Okay, neuropsychiatric manifestations. HIV can cause a wide range of neuropsychiatric symptoms due to both direct neurobiological damage and indirect psychosocial factors such as stigma, chronic illness, and medications, etc. Okay, so HIV can cause a wide range of neuropsychiatric symptoms due to both direct neurobiological damage and indirect psychosocial. Okay, cognitive and neurologic manifestations. Cognitive, memory impairment. Of course, if the networks are not functioning well, particularly if you're getting hippocampal dysfunction. And like it said here, it didn't say the hippocampus here, but yeah, basal ganglia, movement disorder, frontal cortex, executive thinking, personality, planning, white matter, and things like that. That's sort of like this, it's sort of like multiple sclerosis type. Neuropsychiatric manifestation. Okay, slow information processing because none of the hippocampus not working, the basal ganglia, the process is not working. Executive dysfunctioning, meaning frontal lobe damage here will lead to the executive dysfunctioning symptoms here. The slow processing information is still a part of this frontal cortex and the subcortical white matter. Psychomotor slowing. Sure, the basal ganglia is supposed to regulate movement. That's how you get that. Attention deficits. These are frontal cortex damages, right? Language disturbances, basically frontal cortex, also the temporal lobe too, and the Broca's aphasia area. Gait abnormality, tremor, spasticity, or late stage is still the basal ganglia. So when you see, the result is neuronal loss and synaptic loss, particularly in the basal ganglia, the frontal lobe, and the subcortical white matter. So when you're examining patients with HIV and you're looking for the soft neuropsychiatric manifestations of HIV, then you start to look for movement disorders here, cognitive problems, right? And then other things like perceptual and movement disorders too. So they may not be as prominent, so they come up as like asymptomatic and mild neurocognitive disorder, but you can pick them up there. You can pick the deficits up there because they'll have difficulty paying attention or paying to concentrate. So look, memory impairment. They'll have difficulty remembering things. So you want to test their short-term memory, right? You want to test their working memory, meaning the number of items that they can hold in memory at one time. And then you want to see about their long-term memories. Short-term memory, what did you eat yesterday? Working memory, why don't you remember these 12 items for me? And long-term memory, what streets did you come? What high school did you go to? Slowed information processing. These reflect subcortical dementia, characterized by slow thinking, apathy, motor dysfunction, rather than the amnestic pattern of Alzheimer's dementia. Now, remember, the amnestic pattern in Alzheimer's disease is only amnestic because it only involves the hippocampus, right? Alzheimer's, initially, it only involved the hippocampus. It's the acetylcholine receptor nerves that die, right? And so you get a reduce in memory, but it shouldn't involve things like perception, things like mood and all that. That's why with Alzheimer's disease, they're very forgetful, but it's a gradual transition, right? But here, when you're talking about HIV, neuropsychiatric manifestation of HIV infection, look, you're having memory problems again. You're having processing problems. You're having thinking problems. You're having movement problems. You have executive functioning problems. You're having language problems. You're having gait problems. That's different than just Alzheimer's just affecting memory, right? So when they say of subcortical dementia, you're talking about damage to a lot of structures subcortically, and that process primarily happens through what we're describing here. When this exocytation, this process here damages the cells. Okay, here, psychiatric manifestation. Just look at this. Now, let me try to simplify this for you. So it's very easy for you to sort of remember and begin to understand. No matter whatever dysfunction you have, it's only going to produce certain symptoms. You mess the system up, you're going to get a psychosis, right? Or you're going to get a mania, or you're going to get a depression, or you can get anxiety, or you get nothing like cognitive problems, right? You can only fail within certain categories. There's not a new brain failure category, luckily, because you only fails in certain only predictable ways, right? So let me show you here. So look here. So when things fail, psychiatric manifestation, look, depression, look, mania, look, psychosis, look, anxiety, and then look, not only sleep, but other cognitive things, things that's based upon routine, like your appetite, your weight, your sleep, your interest, your motivation, and things like that. So it started to affect those, right? So failure results in mood problems, problems, because think about this. Think about this. When if you're having a virus impact your brain and your brain is responsible for interpreting your reality, all right, if that virus interferes with the functionality of that network, then you're going to have a different reality. The problem is the person with a different reality believes that all that stuff is real, but it's just the impact that the virus is having on their networks that's rendering their reality. Got me? So these symptomatology represents malfunctioning in the network. It's not even personal. The person feels very depressed, sad, and withdrawn, and just feeling absolutely awful. I mean, you grow when you can look at them and say, hey, this is just a decreased serotonin story. Oh, serotonin low. Oh, if the person really psychotic believe all these different, oh, the dopamine is just too high, right? If they can't sit down, if they keep moving, if they're talking all the time, yelling, screaming, arguing, or fighting, yeah, they just have too much norepinephrine, dopamine, right? The stories are connected to what's happening at the receptor and the neurotransmitter level. The story isn't the reality. The reality is what's happening on the network. The story is just the production, right? So here, depression, look, depression, most commonly in 50% of the studies. Look, the mechanisms, neuroinflammation. I told you there's that inflammation again. Look, serotonin, involving serotonin. I told you, right? If those serotonin networks start failing, they're going to present with depression. And then dopamine too. It's a dopamine story too, but more of a depression story. We'll get to the dopamine story later. Read look at the podcast on the dopamine as a neurotransmitter and see how important that is. Psychosocial stressors, mechanisms, psychosocial stressors and immune dysregulation. Look, cytokine-induced sickness behavior. Cytokine-induced sickness behavior, right? When the patient's serotonin levels begin to drop and the dopamine levels begin to drop, they exhibit their networks become hypoactive and they exhibit hypoactivity, right? But then they actually play along with a depressed role too. So when the networks are sort of hypoactive, sure, you get the psychomotor slowing, you get the psychomotor retardation, you start to feel tired, your thoughts start to slow down, not as much interest, not as much motivation, and then all of a sudden you start playing a sick role, playing like you're depressed, when really your networks are just hypoactive, making you experience a state of depression. Y'all got me? Look, so when things go haywire, when it goes up, it goes up. When it goes down, it goes down. Look here, mania, bipolar-like. Look, mania and bipolar-like syndrome. HIV-associated mania or AIDS mania can occur, especially in advanced diseases. I don't think there's anything such as AIDS mania. I think that if you start to get that glutaminergic system hyperactive, you make those glutaminergic system hyperactive, I think you're going to get everything turned up. Let me just tell you this to make it simple for you. You need to look at the presentation I did on glutamate and GABA. There are two main neurotransmitters that's present throughout basically all the tissue. One is glutamate, and remember, it turns everything on. And the other is GABA, and it turns everything off. The main story is a story between glutamate and GABA. And here, this HIV, I guess they're saying HIV-associated mania, meaning, look, mania is this characterized by irritable disinhibition and hyperactivity, right? These seem to be complex manic symptoms that seem to be mania associated with other symptoms like cognitive symptoms and also perceptual disturbances. So this is more than just like mania, right? So they say like AIDS, mania, meaning when you see patients with HIV having mania, the mania is different than just the patient just with bipolar having mania. It is a huge difference. I mean, it's a huge difference. The degree of irritability is too intense. I mean, the level of disinhibition is off the chain, and the level of hyperactivity is unpredictable. I mean, with treating this disorder when the patient is exhibiting mania means you have an emergency on your hand. I mean, this thing can really get out of hand. So you're going to have to make sure you stay in control of watch for these manic type symptoms. And the person is on the ride. They're not able to stop themselves. It's like the avatar goes in its own mode. And unfortunately, they're stuck on it. They're stuck on the ride, and they can't stop until someone like you comes around and help them explain what's going on and why they would need the right medications. Um, Here, psychosis can present as HIV-associated psychosis, paranoia, delusions, auditory hallucinations, often occur with cognitive disorders. Mechanisms may include basal ganglia dysfunction, neuroinflammation, and dopaminergic dysregulations. Now, remember, okay, let me go back here. For depression, think about serotonin. They also said low dopamine levels too. Yeah. Someone take cocaine, their cocaine after when they enter withdrawals, they have low dopamine levels, and it's very difficult for them to get out the bed in the morning, right? You have to let them sleep for that day after cocaine withdrawals. Depression here. So think low serotonin, dopamine, norepinephrine, and also norepinephrine levels too for dopamine too. For mania, think about excessive serotonin, excessive norepinephrine, and possibly excessive dopamine also. And here, however, psychosis is a dopamine story. It's an excessive dopaminergic story. So in the psychosis, excessive dopamine stories sound like horror movies, right? Depression sounds like love stories, right? Heartbreak stories, right? Low serotonin. Mania, Super Bowl. Man just won the Super Bowl. Where you gonna go? I'm gonna go to Disney World, right? So these are stories connected to neurotransmitters. And understand with psychosis is dopamine. And remember paranoia, right? Horror movie. You did this to me. They did that to me. Right. Delusions. You did or you didn't. You did. You did. Is it? What word? Is it? Is it's not? We're really auditory hallucination. That's a dopamine story, right? When you start getting scared, when you start getting nervous, when you start feeling like dopamine, right? Too much dopamine. Often the co-occurs with cognitive decline, right? Mechanisms may include basal ganglia dysfunction, neuroinflammation, and dopaminergic dysregulation. There we are right there, the dopaminergic dysregulation and everything. It's too much dopamine, and now the paranoia, delusions, auditory hallucinations, and mainly the positive symptoms of schizophrenia start to kick in. All right, then of course, anxiety disorder. You start moving around these serotonin, norepinephrine, generalized panic attack, PTSD, common, often secondary to chronic stress, illness, and uncertainty. Okay, great. Sleep disorder due to cytokine imbalance, alter circadian rhythms, or medications. So I typically put patients on things like melatonin to sort of help them with sleep at night. Okay. At this point, let me see if I have any questions right now. Let me see if I have any questions. Mohammed, how's it going, buddy? Nice to see you too, buddy. And Latrice, thanks for checking in, Latrice. And for the students, can y'all start checking in? I want to make sure y'all did these lessons. I gotta find a way to keep up with students. I don't even know if y'all are watching this lecture or not. Let me see. Okay, let me go ahead. Okay, so medication-related neuropsychiatric effects. Okay, and so let's go ahead and I don't really want to cover these. The treatment for HIV, I just want to go ahead and progression and correlation. Acute, chronic, asymptomatic, and advanced. Acute, transient encephalopathy, meaning acute confusion, cytokine storm. This cytokine storm is bad. Headaches, confusion, and mood lability. That's like that initial infection, right? Asymptomatic, chronic asymptomatic, low-grade inflammation. Subdural cognitive decline, subdural cognitive slowing and depression, advanced age, HIV encephalitis, neuronal loss, white matter disease, dementia, psychosis, mania, motor abnormalities, the same areas we're talking about, right? Diagnostic consideration, neuroimaging, an MRI shows white matter hyperintensities, atrophy of the basal ganglia and the frontal cortex. So remember that basal ganglia frontal cortex combination. CFS analysis may show elevated proteins such as HIV RNA. The neuropsych testing identifies hand stages. Yeah. See, the neuropsych testing is how you're going to be able to identify all the different areas here, like the cognitive decline, the functional impairments, and things like that. That's how you're going to, because with the neuropsych testing, you're going to be able to test their memory, you're going to be able to test their abstract reasoning, be able to test their executive functioning symptoms. Okay, yep. And then here, okay, so here's, I guess it's the mechanism. Okay, did I do this one? Okay, management, early and consistent antiretroviral. Okay, I don't want to get into management there. Mechanisms. Okay, the viral protein. The viral protein is one of the ways that the virus, the GP120 or something else, is a way the virus can create the neurotoxicity, and that results in cognitive slowing and apathy, right? Apathy is a very significant one. That's when apathy can be, that's when there's simply like no emotional response at all. It's really stunning when you're talking to patients who have real apathy. It's like you're in a room with a vacuum, and like everything comes out, nothing echoes back. It's like that. But the apathy is usually associated with movement disorders, particularly in the basal ganglia. So the HIV's predilection for the basal ganglia may be one of the reasons why the cognitive slowing and apathy can be so much very prominent. Okay, this cytokine mediated storm, right? Okay, neurotransmitter imbalance, great, yeah. So it makes it imbalance the neurotransmitters in the synaptic cleft. The frontostriatal circuit damage, executive function. Yeah, here it is. So it's that frontostriatal circuit damage. Did I do, I think I did a presentation on the frontostriatal pathway. Let me see, did I do that? Let me see. Dorsolateral, we did the dorsolateral. Okay, great. About the dorsolateral prefrontal cortex, amazing. This is very important right here, the dorsolateral prefrontal cortex here. So I think the next one I'm going to do is on this circuit here, the frontostriatal damage here. I'm going to put that down. Let me put that down for tomorrow. Let me look here. So I'm going to do this one tomorrow noon. Okay, frontostriatal pathway. Okay. So it's damage to this circuit that causes the executive functioning system, the executive functioning difficulties, which results in disinhibition, right? The purpose of the frontal lobe is to shut things down. Remember, in attention deficit hyperactivity disorder, this network is hypoactive, right? Because it's hypoactive, the frontal lobe is not as dominant or is not as engaged in turning things off. So we give people stimulants not to stimulate their body, but to stimulate this pathway so that the frontal lobe can be more dominant, and therefore it can trigger suppression and inhibiting everything around this. So the clarity of thought and the consciousness you you enjoy is because your frontal lobe is suppressing absolutely everything except that one thought you want to have, right? So that inhibition is limited at that point. Here also mania, right? I believe left-sided frontal lobe injuries, I think, associated more with depression, and then right-sided associated mania. But look that up. It's one of those. One is associated more with depression more, and the other associated more mania. So with that frontal lobe damage, you get the mood disorders, right? You also get the personality changes and the personality disruptions also. So the person the person loses the ability to read social cues, and the judgment and things like that become skewed. So they start to have a lot of interpersonal difficulties. But apparently, HIV damages that network. Okay, ART side effects, neuropsychiatric symptoms, insomnia, vivid dreams, and anxiety. Would you like me to include a schematic or visual diagram showing how? Would you like me to include a schematic or visual diagram showing how HIV invades and affects the CNS and leads to these psychiatric outcomes? Why, yes. It would make a disease process much clearer visually. Why, yes. Okay, so what I do? Okay, do yes. And then what it do from there? Hey. Let me see what's happening here. I guess it's going to take time to generate it. Be interesting to see what it comes up with. Uh-oh. And this is moving fast, y'all. I don't think we're going to need textbooks anymore. Okay, let me see. Oh, I think it's coming. Still rendering, folks. I can't wait to see. I think it's going to be really nice. I can't wait to see it. Almost there. Almost there. I think just a little bit left. Well, let me do this then. This is the free version. Well, let me move on. I think that's it. If it comes on, I'll let you guys know. Oh, okay. Oh, here it is. Here it is. Okay. So here, neuropsychiatric manifestation of HIV infection, pathology, the brain effects and magnification, HIV, infected monocytes, infected macrophages, right? Release of cytokines, glutamate. Glutamate causes the release of cytokines. It primarily affects the basal ganglia, particularly subcortical white matter, and the manifestation is cognitive slowing, apathy, depression, and executive function. This is great. And then, I think this diagram only includes all of the important parts of this. Yeah, look, monocyte, macrophages, cytokine, glutamate, basal ganglia, subcontinental myelin. Yeah, this is great. Well, I think that's all I need for now, guys. Uh, Again, it's a pleasure to work with you guys. It's a pleasure. Um, if you have any other questions, feel free to give me a call. I mean, feel free to leave a question in the answer in, in the comment section, and feel free to like, subscribe, and share. Okay. Hopefully, it's very helpful for you guys. Take care, guys. Read out. Ciao, guys.